Yeah.
Good morning. Good morning all. I am Lina Lasminingrum and I am the host of this webinar today. First of all, I wish you a holy Eid Mubarak. May you and your family be blessed with healthy and safety. Let our endless prayers will get us through this pandemic and hope it will gone soon. Today, happily I announce that we have Professor Yong-Ju Jang from Asan Medical Center, University of Ulsan College of Medicine, Korea. Thank you, Prof. Jang. We are honored to have you here. For your information, this learning module program is initially dedicated to OLL residents in the pandemic era, but it's open to OLL specialists also. Surprisingly, today we have participants for around 16 countries around the world. I welcome you all the colleges for around the world. Thank you for joining. This is such a big event. And thank you, Prof. Jang. I may say that you make this happen. Next, I will hand it over the session to our moderators. The first one is Dr. Trimartani Koento. She is now a chairperson of Indonesian College of Otorhinolaryngology Head and Neck Surgery, and also a director of human resources in the biggest hospital in Indonesia, Cipto Mangunkusumo. And the second is Dr. Dini Widiarni. She is a chief in Indonesia Fascioplastic Reconstruction Study Group. Dr. Ria and Dr. Dini, the session is yours.
Thank you very much, Dr. Lina. Good morning, Professor Jang, and to all participants. Welcome to our Indonesian College of Otorhinolaryngology Head and Neck program, especially module for facial plastic and reconstruction. So this program is our continuing program, which will invite international and national guest speakers sharing knowledge, not only for Indonesian ENT surgeons and residents, but also for other countries out of Indonesia. And today is our honor for Professor Jang. Thank you for coming and receiving our invitation. We have about 555 participants from Indonesia, of course, and other 19 countries. Of course, for those Muslim, I will send happy Eid Mubarak. So this is our second celebration after 1 month of fasting Ramadan. Before we're about to start, our host will silence all participants to have a better sound quality from Professor Jang, and participant could raise their questions on our chat wall or just raise hand. So now is about 8 o'clock past, so I would like to please Professor Jang to start his lecture. Please, Professor Jang.
Good morning. Professor Ria, Professor Dini, Professor Lina, thanks for invitation. It's my great pleasure to talk about correction of the deviated nose. And this morning, I welcome all of the participants from Indonesia and other part of the world. So can you see my slide title? This is okay.
The slide, I think the sound is not clear.
I will make my voice louder. Okay.
Okay. Yeah, thank
today,
you.
I'm going to talk about deviated nose and the correction of deviated nose and its breathing function. I was also asked to talk, put more emphasis on the function, so I'll also do that. Can I start now?
Yes,
please.
I'm sorry for the delay. So this is repeat. What about this is? Oh, I want to, okay. This black one is continually, okay, good. I think I can start now. Today, I'm going to talk about the correction of the deviated nose and its breathing function. I'm from Seoul, Asan Medical Center. Thank you again for the invitation. I think that this now it's morning in Indonesia and Korea, and
Yes.
maybe evening, afternoon, or evening in other part of the world. Yeah, rhinoplasty, as you know, it's surgery about dealing with form and function. You know, form and function are equally important, especially in nasal surgery, especially in rhinoplasty. I know that you are really familiar with the anatomy of the nose. The nose is consisted of nasal bone and frontal process maxilla and upper lateral cartilage and lower lateral cartilage. Inside of the septum in the nose nasal cavity, the septum is consisted of septal cartilage, quadrangular cartilage, and perpendicular plate of ethmoid and vomer here. When you look into the nasal cavity, as you know, there's inferior turbinate and middle turbinate. These has significant importance in regulating the airflow. I strongly believe that the nasal septum is just like a pillar of the structure of any building. So this pillar has tremendous importance in shaping the entire the shape of the building. So this is an analogy using this pillar and tent. If you have a pillar which is straight and no deflection, your airway will be fine and the tent will look fine. But if there is any deviation, it will show us like just like saddle or deviation, or sometimes even very small loss is also related with extremely underdeveloped septal cartilage. So this is the CT scan of the patient who has deviated nose. As you can see here, here is the caudal septal deviation to the left side. And this patient is he has deviation on the right side. I strongly believe that the caudal septum is the most important structure in regulating airway. We always talk about nasal valve, but I think if you can correct this caudal septum very well, you can correct almost all abnormal airway function. So I always put my every effort to correct this caudal septum properly. This is a computational flow dynamic diagram of the airflow. The normal airflow has a curved flow, and it distributed mostly around the middle turbinate, but generally to the whole nasal cavity. And then it's the airflow is warming and humidifying the air. But when you have the patient has severe deviation like this, the airflow is deflected and is deviated, and it's changed like this. So then patient have discomfort. Earlier, I studied about the frequency of the nasal obstruction in patients with deviated nose. In my early study, not all patients, but about majority of about 81.8% of the patients who come to me with complaint of deviated nose has nasal obstruction. So yeah, I think the 80% is a big proportion. So when we deal with the patient with deviated nose, we have to already think about the function if they have any functional issue. And let me start with the classification of the deviated nose. Earlier, I classified the deviated nodes into 5 different types, which was published in 2008. So I simplified the deviation depending on the axis of the bony deviation and cartilaginous deviation. Type 1, for me, it is a deviated bony axis plus tilted cartilaginous dojum. Type 2 means deviated bony axis with curved dorsal cartilaginous dojum here. Type 3 and 4 has relatively straight bony dojum in the middle line, but cartilaginous dojum is tilted, curved. Type 5 has deviation starting from radix to the tip all the way down from the radix to tip in one direction. This is the type 1 patient I explained. After the correction, I could make his nose much more straighter. Can you see the something is strange line here? No? Okay. I don't know what this is, but I will go on for the sake of time. This is the patient who has type 2 deviation, who has tilted bone with curved cartilage. Okay, please remove this. Oh, thank you.
Yeah, okay.
Okay.
Sorry.
And her nose became straighter after the correction. This is the type 3 patient who has relatively straight midline placed bony dojum right here and tilted cartilaginous dojum, linear tilt, and this was corrected nicely. Type 4 deviation, relatively straight bony dojum and curved cartilaginous part. So we have to correct this cartilaginous lower 2/3. That's what we have to do. This is type 5 deviation who has linear deviation from here to here. For me, this is one of the most difficult deviation because they usually has combination of facial asymmetry. When you check the CT scan of the patient with deviated nose, sometimes they have convexity or concavity in the bony sidewall. We can correct the bony axis by performing osteotomy, or we can reduce this convexity by rasping or by using this is the piezotome. I used to use this many months ago. And when there's a concavity at the bony sidewall or cartilaginous sidewall, the concept of camouflage is very important. So we can call it as unmade grafting, or we can do it camouflage graft. What I use is mostly crushed cartilage. Sometimes I use a small piece of Gore-Tex.
Professor Jang, can you speak louder?
Okay. But I think the osteotomy is the key maneuver for correction of the deviated bony axis. So I usually, let me explain how I do osteotomy to correct the bony deviation. If there is any convexity here, what we can do is just do medial and lateral osteotomy and medialize this segment. When there is concavity, what we can do is make a medial osteotomy and the lateral osteotomy and then lateralize this segment. But in most cases, we do need to do something more because many patient has deviation at the midline axis like this. Then we have to be able to fracture this midline bony segment and mobilize this bony segment in the middle. So this can be done by fracturing using your finger, but in some situation, it's not that easy to make a controlled fracture in the middle. So in that case, what I do is the percutaneous root osteotomy, which I published more than 10 years ago. Let me explain this. I explained that we need to reshape the bone by medial and lateral. After medial and lateral osteotomy, we do medialization or lateralization of this segment. But if we have still deviated mid part, then I do insert 2mm osteotomy to do percutaneous root osteotomy. So this video clip will show you how I do the osteotomy. I start usually with a medial osteotomy using 3 millimeter sharp osteotomy. I do medial osteotomy bilaterally, and then I do lateral osteotomy via internal laser route using a curved guided osteotomy. Then I try a fracture at the midline bony segment by manual force, but sometimes it's not that easy to make a controlled fracture. In that case, I do percutaneous root osteotomy. As you can see here, I can fully mobilize this segment, midline segment, so that I can make the bony axis straighter. So this is the case who benefit from osteotomy. I sometimes call it a triple osteotomy: medial, lateral, root osteotomy. And as you can guess easily, this is not what I have to do. This is not the only one I have to do. I have to do some cartilage work, camouflage or spread grafting, whatever, to correct this cartilaginous deviation. And as you can see here, she has now much better profile look. This is a relatively mild type 5 deviation starting from radix to the tip. So I did triple osteotomy, and I relocated this caudal septum to the right side of the anterior spine. That's what I did. So this is a lateral view. But for me, the most important difficult part of the deviated nose correction is correction of the cartilaginous deviation as shown here. As you know it, cartilage has a strong memory just like a spring. So it's very difficult to overcome the intrinsic cartilage memories. So in order to do that, I spent a lot of time during surgery. I do many procedures to correct this cartilaginous deviation, and this is also a very important procedure for properly correcting the nasal function. I normally classify the septal correction technique into two. The first one is inside technique, and second one is extracorporeal septoplasty. My inside technique means that I manage the cartilage as not detaching the whole L shot. I mean, I can do repositioning, spread graft, the cutting suture technique, a batting graft. I will explain this one by one. And yeah, spread graft, I know that this is one of the most famous technique in rhinoplasty. I know that you know that this will widen the internal nasal bell, but for me, the main use of this spread grafting is mostly for straightening this deviated dorsal L strut. And you can also widen the dorsal cartilaginous dorsum a little bit. So I would say that I use spread graft about 70 to 80% of my deviating nose patients. And this is the patient who came to me with not that severe deviation, but he didn't like the mild concavity right here. So what I did was I placed one relatively thick shield graft using septal cartilage right here. And then I could make his nasal dorsum straighter. I didn't do any osteotomy. This is frontal view post-op. This is lateral view. I did a little bit of hump reduction here. This is another case who also didn't like her nose, which looks deviated to the left side. So in her case, what I did was osteotomy and spread grafting. And I did a little bit of dorsal augmentation because many Asian patients want to have more defined, more bigger nose as a result of rhinoplasty. So in an Asian rhinoplasty tip surgery for the tip correction of deviated nose, dorsal augmentation is a big part. So you have to know that. So as you can see here, her dorsal line became smoother and augmented, and tip projection was also achieved. This is a typical operation for deviated nose. So in summary, spreader graft can straighten the curved dorsal hairstrut, while it can widen the middle nasal bolt. But I think that we don't have that much discussion about how we have to do. Do we have to place it bilateral or unilateral? Do you have to place it a single or multiple? So let me summarize just some of this aspect. I like to use combined unilateral extended spreader graft like this one, and with a caudal septal extension graft like this one, because many deviated nose patients want to have augmented nasal, augmented nose. So if the patient has deviation to the right side, and if I found the spine is a little bit off axis to the left side, then I place septal extension graft on the left side. This will act as a new center of the new nose. This is innate native septum. And this is extended spread graft. So from above, you can see something like this one. What it does, this spread graft will splay apart. It will efface this lower part, and then it will make the nose look less deviated. So this is not a complicated concept. This is very simple concept, but I recently summarized my concept and published in 2019, just a few months ago, in Annals of Otolaryngology. So the title is Centering a Deviated Nose by Caudal Septal Extension Graft and Unilaterally Extended Spreader Graft. The indications are the tilted cartilaginous dorsum with off-centered nasal spine. If the patient are in need of caudal septal extension grafting for tip projection, this is adequate indication. And you should be able to, should have cartilage of adequate thickness and strength. But there's some modification. I use bony batten graft a lot in my rhinoplasty. Yeah, this can be placed here and here and there. And you can also put multiple spreader grafts like this. And you can place new caudal septal extension graft in between two extended spreader graft. Let me share with you one case. This lady didn't like her deviation to the right side and hump here. So I opened her nose. I placed one small bony batten graft on the right side to straighten the caudal septum. And then I placed extended the spreader graft on the left side, and I placed caudal septal extension graft right here. And I placed one more spreader graft on the left side in order to make the left side of the nose more wider. So here she is. As you can see, her nose looked straighter, and nose frill became wider, and her profile view looks better. This is another case. I also applied bony batten graft on the left side of this patient, and I placed one caudal septal extension graft, and I placed one spreader graft on the left. So after this maneuver, her nose became straighter, nose became projected, tip projection was achieved. Another case, similar one. I placed bony batten at the dorsal aspect and caudal aspect of the septum, and then I placed one spreader graft and caudal septal extension graft placed on the left side, and one more spreader graft was placed on the left side. So here he is. As you can see, this is not a big severe deviation, but as you can see, his nose became straighter, profile view is improved. I have another technique which I like to use from time to time. One day in the middle of surgery, I had a real trouble in straightening this deviated dorsal septum. So I cut it, and then I found it worked great to straighten the deviated dorsal hairstrut. So I cut it as cutting and suture technique. This worked nicely for the angulated deviation. This patient has deviation to the right side. So I use this cutting and suture technique at the dorsal part, and then her nose became straighter. As you can imagine, I did some tip work and some dorsal work too. And I use batting graft a lot. So I started using this batting grafting of more than 15 years ago. And I published it first about the cartilaginous batten. It's simple. If you have a caudal septum which has concavity, convex to the right side, you can counter the convexity by placing a convexity to the opposite side. Then you can make it straighter. This is batting graft. And you can also use bony perpendicular plate of ethmoid or vomer, as I showed you in my video. When I remove the bone, I usually try to do it conservatively. I make a horizontal cut at the perpendicular plate of ethmoid after removal of the cartilage. And then this is rotated and gently delivered out. And then I make few holes using drill. And then this can be used as a batting graft to correct the caudal septum. And sometimes you can use a smaller piece to place the batten in the inferior part of the caudal septum like this one. And this is very strong, robust, reliable technique. So this is intraoperative view after the placement of bony batten. I like to use this technique because Asian patients tend to have a relatively thin and weak septal cartilage. And in contrast, the bone is usually thin, especially the PP is very thin but strong. And this use of bone can spare the harvested septal cartilage to other purpose. If I use this bone for septal correction, I can use this harvested cartilage for tip work. In my experience, this is safe. This has longevity. So this is a patient who happened to have a post-op CT 2 hours after the placement of the bony batten. As you can see here, there was no resorption. I didn't put very thick on. It's not just moderate thickness. I placed it at the dorsal part and caudal part. As you can see here, this bony batten is preserved very well. It's about 3 years after the surgery. As you can see here, there's a hole. This is the holes I made using drill. But there are some drawbacks. Some patient complain that I feel my tip a little bit too stiff. Sometimes it can irritate the mucosa, soft tissue around the nose. So it's very important to cover one side of the bony batten with the cartilage. And sometimes if the patient got injured, it can be fractured. I have very few patients who develop olfactory function. And hematoma is relatively common, especially at the posterior part of nasal cavity. So you have to know that. When you remove the nasal septal bone, sometimes you injure the olfactory nerve coming out from the skull base. So you have to be careful not to remove too much of the perpendicular plate of ethmoid. So I analyzed my surgical outcome and I published it in 2017. Let me introduce you some of the result. After the surgery, most about 60% of patients have good improvement, and 45% has improved. But there are a few patients who didn't have a good improvement. When it comes to complication, I told you that septal hematoma is relatively common. It's because I removed the bone at the posterior part of the nasal cavity. Sometimes there's a delayed bleeding, and because and sometimes there's a complication of chondritis and hyposmia. I have 2 patients, but this was treated with a steroid. They recovered very well. The revision rate was about 2.8%. And this is the typical case who benefited from the use of the bony batten. I used the bony batten graft on the caudal aspect of the septal cartilage and also at the dorsal part. So now she has, although she has facial asymmetry, her nose looks straighter compared to the pre-op condition. This is basal view. And I talked about the using batten on the caudal aspect, but I sometimes use this bone just like a spreader graft. This is very powerful technique to straightening the dorsal septum. In this particular individual, I could get a good decent piece of bone from the septum, and then I placed it just right here. It acted like spreader graft. As you can see, his nose became straighter, and I also reduced his hump like this. In Asia, hump is not that common, but I think in Korea, in this northeastern part of the Asia, the hump nose is quite common problem. And I use also this cutting and suture technique at the caudal septal correction of the caudal septal division. It's wonderful. It's very powerful. So this is my earlier publication about the this technique. This technique is just about the septal correction, not about the rhinoplasty. So it means that you can use this cutting and suture technique for correction of the caudal septal deviation for your ordinary septal surgery. So here is caudal septum. I cut it right here, and I do overlap a little bit here, and then because of the insurance, as an insurance policy, I placed one bony cartilage batten right here. It's very important not to overlap too much. If we overlap it too much, the caudal septum became shorter, and then it will cause cellulose.
Caudal strut is cut using scissors at the convex most region in the caudocephalic direction.
So I cut it right here, and I move the upper part to the right side.
Overlapping cartilages are sutured together using 3 to 4 stitches
here,
using 5
the caudal
PDS.
septum look straighter. And then
septal batten graft, harvested from
make
central
sure
part of the
the
cartilage,
straightness and
is
strength
placed
of
for
the
further support,
caudal septum.
usually
I
on the concave
sometimes
side.
place bony batten or cartilage batten, but you can do it without any batten grafting. This is the patient who had typical cartilaginous deviation. So by using this technique, I was able to straighten her nose from here to here. And this is a lateral view of this patient. The minor hump was reduced and tip projection was achieved. Yeah, this is brand new technique. I recently published it just last year. This is a relatively new technique I like to use these days. So I call it as a caudal septal division and interposition batten graft. This is kind of modification of the batten grafting and cutting and suture technique. Let me explain what this is. Sometimes we have patients who have a convex caudal septum like this. Then what you can do is you can place bony batten or you can do cutting and suture, but sometimes you can cut it here. You can interpose batten graft. This can be cartilage or this can be bone. And this works great in a certain situation. This is the video clip of the interposition batten grafting. So I cut in the middle to correct the deviation, and then I place a relatively thick cartilaginous batten graft. The beauty of this technique is that you can adjust the height of the caudal septum. You can make the caudal septum higher by making a new position of this part to more higher position of the interposition batten graft. You can also use bone in this purpose. So this is the end of the surgery. So as you can see here, the caudal septum looks straighter and a little more higher. So I sometimes use this technique for correction of the deviated dorsal strut. So in this case, I cut right here, and I placed one big spreadograph light thing here from right side to left side. I didn't have any, I don't have any publication of this, but you can improvise, you can use this technique for dorsal septum or coral septum. Let me summarize the merits and disadvantage of this technique. This technique is easy to adjust the caudal septal height. And this is effective for correction of a severe caudal septal deviation. You can ensure stable septal support, but the demerits are this graph can be tilted. Sometimes it causes increased caudal septal thickness. This patient is typical case who underwent interposition batting grafting. As you can see here, his cartilaginous deviation is nicely corrected, and his profile view is also improved. Another case, deviation to the right side. So I used interposition batting grafting. I also used spreadograph in order to correct his deviated nose. So as you can see here, now his nose looks straighter. Improved profile line was achieved. I'm sure that extracorporeal septoplasty is very famous, and you all know this technique very well because the master Dr. Wolfgang Gobisch taught this technique all around the world. Yeah, I was also influenced by his lecture and his paper. And originally his technique is removing almost all septal cartilage, including the cartilage and bone, as a one piece, and then reshape and reinsert it. But personally, I found that it's not that easy to follow his technique, probably due to the lack of my technical skill. So I modified this technique a little bit. So I published my modification earlier. Let me explain. The idea is simple. Dr. Sam Most has a similar publication. He called it anterior septal reconstruction, but I call it modified extracorporeal septoplasty. What I'm doing is I preserve some cartilage at the keystone area. This will be used as an anchoring point for the new iron strut. And this is extracorporeally designed new iron strut. And then I re-implant it at the original septal location. I try not to make drill holes. Instead, I try to use suture technique. In order to do that, I usually preserve soft tissue around the nasal spine. And then dorsal part, it is suture fixated with preserved cartilage. Indications are severe deviation, the patient who has strong and big cartilage, patient who has, this is severely deviated cartilage. So this video shows how I do this. And I'm opening this nose, and I'm dissecting the badly deviated cartilage, septal cartilage. You can see the cartilage right here. And I removed the cartilage and bone, and I'm doing osteotomy, medial and lateral, and then I'm designing this excised cartilage and bone. I use ear surgery drill for making drill holes. Yeah, this is L-shaped cartilage. This will be placed at suture to the right side, and then I place something like a spreadograph on the left side, and then I reinforce this whole septum with bony batten grafting. Here he is. As a result of this endeavor, his nose became straighter, as you can see here, from here to here. Looks very straight. Ala deformity, he has a tilted columella and asymmetric ala lobule here, and this is also improved. profile line is also improved. This is another case who has very severe nasal obstruction. So in this case, I make a new insert just like tuning fork at the dorsal part. It is sutured with the cartilage, preserved cartilage, and caudal part is reinforced with bony batten. So here he is, as you can see, his cartilaginous deviation is improved. Dorsal tip projection is achieved. This is intraoperative view of one other patient who had a very severe deviation. So I removed his cartilage, and then I reconstructed new cartilaginous L-strut, and I reimplanted. And then additional surgery was done with remaining septal cartilage. This is about 2 years post-op result. As you can see here, I didn't do that much dose augmentation, but as you can see here, his nose looks very, very straight compared to the pre-op. Profile line is also improved. Another case, young lady who had trauma in her childhood, developed severe deviation, mild saddle. Her nose was improved by using extracorporeal septoplasty. As you can easily imagine, I think this is a much more fundamental technique. You can also adjust the dorsal and tip height. But let me tell you, this is not that easy technically. You need to have a learning curve, and sometimes there's a risk of jeopardizing the stability of the keystone area. This is my case. I had a good success in correcting his deviation. In 6 months post-op, dorsal line was also fine, but he developed saddle about 1.5 years later. So I published my comparison of the in situ technique and extracorporeal the septoplasty technique. This was publication of 2014. In my analysis, the aesthetic outcome was quite similar in both groups. But interesting thing was that in extracorporeal septoplasty group, all patients were very much satisfied with the function. But inside the group, I have a number of patients who have persisting nasal obstruction after the surgery. So for me, the functional, in terms of functional correction, the extracorporeal septoplasty is better to be chosen. And I think we need to have some more final refinement technique. As I told you earlier, augmentation and camouflage is very important, especially in an Asian patient. For the augmentation, I use ear cartilage with perichondrium dicet. This is diced ear cartilage with perichondrium around. You can easily eliminate the convexity and concavity of the ear cartilage. I sometimes use homologous fascia combined with crushed cartilage. Oftentimes I use Gore-Tex. Nowadays, my favorite technique is using diced cartilage, shaped with my cartilage mold. I call it Jang cartilage mold. So this diced cartilage shaped with this mold is wonderful tool for augmenting and camouflaging the nasal nodule. So this is diced coastal cartilage. This is fashioned dorsal implant with diced cartilage bottom and fascia covering. So in this patient, he has deviation to this way, and he also wanted dorsal augmentation. So after executing various maneuvers for correction of deviation, including osteotomy and spreader grafting and caudal batten grafting, caudal septal extension graft, I harvested a little bit of ear cartilage, and then tip surgery was done. And then, as you can see here, his nose became straighter. The profile line was improved. So let me emphasize this one. in order to properly correct the deviated nose, dosal augmentation has much more important role than you think. So in this patient, after finishing the cartilage work and septal work, I augmented his dosum centered on right side. Then you can get something like this result. After correction of deviation, I augmented his whole nasal dosum, especially I camouflaged this side. So camouflage and augmentation is very important concept. Let me briefly introduce my cartilage mold. This is a patented mold. It's available in the market now. And I diced the cartilage with using a blade and a Domaton blade. I diced it very finely. And then this is homologous fascia, which this will prevent the dosal irregularity, which can occur as a complication of diced cartilage graft. And then I removed the, okay. And then I reassembled the second part. I call it as a guarding frame with the side hole. And then I place the glue, fibrin glue first. This is fibrin glue, and this is diced cartilage. And then I apply the fibrin glue again. And I apply a little more diced cartilage. And then finally, I put a little more glue right here. And then because this glue can create a false volume, it's important to remove the water around the diced cartilage and glue around the diced cartilage. That's why I compress it. And through this side hole, you can remove the water around the diced cartilage and glue around the diced cartilage. So here, after doing this, I disassemble this mold, and then I can have dosal implant, which has concavity and convexity as desired. So you can use this material for dosal augmentation. So this is the patient who underwent augmentation and deviated nose correction using coastal cartilage. So I augmented his dosal with glued diced cartilage using my mold. And let's think about the surgical outcome. I can tell you, deviated nose correction is not easy. It's very difficult. You think that now you master the technique, but it always will already hit you. It will bother you because there's a failure. So I analyzed my data earlier, and my revision rate was about 6.5% for the deviated nose. And the just 80% has a successful result. So I think this is reality. This can be due to my poor surgical skill, but I think this is reality. So deviated nose correction is difficult. So I could get excellent result, good result about 80%, but not that good result about 20%. So always is difficult problem to deal with. The problem is you can have a nice result in 5 months, 6 months, but the nose will eventually show its final shape like this one. So this is about 2 years post result. It's very disappointing to see this recurrence of this deviation, but this is pretty common story. And for me, the mild deviation with linear deviation was most difficult to correct. In some patients, you have very nice shape, but they are unhappy because they cannot breathe very well. This can be also common problem. So revision surgery is a reality. You have to live with. In order to do revise, you should be able to completely mobilize the bony pyramid. But let me emphasize this one. You should be able to have a very strong cartilage to reinforce the septum again. So in revision case, I usually use coastal cartilage for reinforce the deviated septal cartilage. So this is the patient who, was my fourth operation. He got 2 surgeries elsewhere, and I use coastal cartilage to make his nose look straighter. One last thing you have to think about is the facial asymmetry. I think that deviated nose is not that simple problem. It's not a problem of the nose. My strong belief is that it's a just manifestation of the asymmetric facial skeleton. So the frequency of the facial asymmetry in deviated nose is very high. So you have to know that. This patient visited me with the complaint of that he has deviated nose, but let's look at his face. Whole face is asymmetric. Even after the surgery, the nose looks deviated. This patient didn't like her nose, which looks deviated to the right side. As you can see here, he has low face asymmetry. I corrected her nose. She got happier, but still her face looked asymmetric. This is very severe low face asymmetry. Before the surgery, I warned the patient that correction of the deviation may be impossible, but I can make your nose little better, little higher, but it's almost impossible. So she accepted that, and then we underwent surgery. I want to tell you one more thing. When the patient has a facial asymmetry, usually they have asymmetric ala base. I found that they are very, very concerned about this problem. So it's better if we have some technique to deal with this. I call this ala lifting procedure. This is a modification of the hanging ala correction technique, which was championed and taught by Dr. Ed Yap in the Philippines. But instead making excision at the lateral inner side of the ala, I make skin excision at just inside of the nostril seal, to pull up the nostril seal and nasal base. So this is intraocular video. So I excised the soft tissue about 0.7 centimeter width. And then I reapproximating it, to pull this part up. This is not that powerful, but this can work in some patients. So I think you better have this technique as an armamentarium in managing the deviated nose patients. So this patient, as you can see here, she has tilted ala base right here. So I use this technique, and as you can see, it's better now, a little more. Similar, this tilted ala base looks a little better after the surgery. So in summary, my techniques for deviated nose corrections include many of these. The red ones are my original technique. Actually, I like to use this a lot. Let me summarize. Again, rhinoplasty, especially the surgery for deviated nose, should be the surgery about form and function. You cannot neglect anything. You have to respect both equally. Then you can fly, the patient can fly. I think that I mastered correction of deviated nose, but always it gives me a lot of frustration. So for me, it's still one of the most difficult operation. And I recently opened my YouTube channel for rhinoplasty video library. You can visit here, and then you can see some of my edited videos. Thank you for your attention. Thank you.
Yeah, thank you, Professor Jang, for the interesting presentation. So you mentioned just now a lot of key factors. One is we did need to do a lot of septal reconstruction because septal is actually the pillars of the nasal. So when the septum is deviated, definitely the nose of the nasal will be deviated as well. Secondly, you mentioned about the triple osteotomy. The triple osteotomy often needs plus the camouflage graft, and then also about combined unit of septal graft and extension spreader graft. Sorry. And the other about the bony batten graft, and also about the interposition of the batten graft. That is very interesting. And of course, finally, congratulations with your mold dice cartilage, Professor.
Okay.
There is several questions raised already. One is from Indonesia. He asked about how do you prevent or avoid septal perforation, because we did a lot of resection or grafting from the septum.
Yeah.
Yeah, and then the other one is about if you have a cartilage deviation, do you need an osteotomy, nasal osteotomy? And of course, the other one from Dr. Satya is deviation correction in Asian nose and in Arabic nose. That is, for the time being, there's 3 questions, Professor Jang.
Okay. Yeah. First, to prevent the septal perforation, I think the single most important thing is elevating the flap in the right plane. You should be able to dissect through subpericondylar plane. Even with the good dissection, sometimes there is mucosal laceration where there was the big spur. So here's what I do. I try my best to elevate the flap in the right plane. And if there's any mucosal injury, I insert some crushed cartilage or soft tissue in between. Third, I use some elastic splint. Lastly, I have 2 perforation case of myself. It was caused by too much tension in the suture of the elastic sheet. So when you place any transmembranous suture or when you place elastic sheet, try not to put too much pressure on the nasal septum. It can cause pressure necrosis. The second question, I guess, is the when there is a cartilage deviation, do I need osteotomy? I try not to perform osteotomy because if you don't do osteotomy, you can have more stable nose. But if you do osteotomy, I think it can deteriorate the stability of the nose. So I better not to perform osteotomy when I don't need to do that. So third question, deviant nose correction in Asian and Arabic. I have a number of experience in the Arabic patient who has deviated nose. The big difference is that many Arabic patients has they have a combination of combined humps, so you should do hump reduction well. In contrast, Asian patient, we need to do augmentation in many cases. And also the quality and size of the cartilage is also different. I think that for the rhinoplasty surgeon, Arabic nose is better nose. Asian nose is not that good for rhinoplasty because septal cartilage is usually small, especially the young ladies, they have very thin and septal cartilage. So we sometimes need to augment the cartilage with the structural grafting.
Okay. Thank you, Professor. So that is the main difference between the Asian nose and the Arabic nose, a stronger, rigid cartilage for reconstruction. Another question is, among implants materials such as Gore-Tex, concha cartilage, fine dice cartilage, fascia wrap dice cartilage, or fibrin glue, which do you prefer most for dorsal augmentation to correct deviated according to your experience, Professor Jang?
Yeah, as I said recently, I prefer diced cartilage shaped with glue, glued diced cartilage, because the volume is good. It has fewer complications like infection, inflammation than alloplastic. Now that's my favorite technique. But as you know, during my 10 years or something, I changed my technique a lot. In certain period, I use this one. In certain period, I use this one. Now I ended up with this diced cartilage with glue. I think that this will be my final last technique. I think I will not change it anymore. Yeah. Hope.
So, thank you, Professor. There is another question. This is considering within which is better to choose endonasal or open approach to corrective various type of deviated. And then another questions about the tip rhinoplasty. Some literature stated that supratip rhinoplasty is the best choice for dorsal hump and polypic deformity. Some also stated best for elderly due to the prevention of dorsal hump in future. According to you, Professor, can we perform supratip rhinoplasty placing the common rhinoplasty?
First question, approach. I prefer open rhinoplasty approach, except when the patient specifically asks me to do it endonasally. It's because I feel much more comfortable in diagnosing and executing all the necessary technique. So in my series, I have a better surgical outcome when I use open rhinoplasty approach. In my early career, I also used endonasal approach, but I had a number of failures. So I changed my technique into open rhinoplasty these days. And the second question
about the tip.
I don't know what it means, the supratip rhinoplasty. I don't know what it means. Yeah.
Maybe this is to overcome the elderly due to elderly process. Usually they have a tip downwards rotation because of the laxity of the cartilage or the collagen fibrous tissues in elderly. So they tends to have a drooping tip and then cause a pseudo hump. Does this supratip rhinoplasty will overcome this process from elderly patient?
Okay. Yeah.
So I think that is another topic to talk, right, about the elderly rhinoplasty.
Yeah.
Okay.
But
so
I think
this one,
in Asian rhinoplasty, if you can secure strong septal support and good projection, most of problem that mentioned previously can be avoided. Yeah. That's what I think.
Another question, Professor. What is the consideration to make a hole in the graft and why we consider using harvest from the costal bone and concha of the ear for grafting?
You mean why I use bone instead of?
Yeah. And then why do you use a hole? You use a bore, right? To make holes in the graft. Yeah.
When we use cartilage, we can easily suture through the cartilage. You can easily fix the cartilage to the septum, but bone, you cannot pass the needle through the bone. So that's why I make many holes at the bone graft. It's just for suture material passage. But you have to do it in a blind manner. So that's why I make many holes. as many holes as possible.
Okay. So
And-
this is also a good question. So is there any consideration to choose better with endonasal or open approach to correct the various type of deviated nose, Professor Jang? And is it correlated with the degree of obstruction?
You mean the, so can
So if,
we,
yeah,
can
you
we-
divide it five
I see.
type.
Oh, yeah.
So which one is endonasal or which one is the open approach?
Yeah, frankly speaking, I don't feel that confident on the endonasal technique because
Okay.
yeah, spread graft placement is not that easy, and yeah, we can do it, but it's not that satisfactory. And yeah, we can correct the caudal septum well. Yeah, let me tell you, I think if you are a skilled surgeon in endonasal rhinoplasty, I think you can do, there is no limitation. You can choose any types of deviation for your endonasal rhinoplasty, but I think it's a matter of choice and matter of expertise if when it comes to the endonasal open rhinoplasty option. I know that there are many good surgeons who can do very nice job managing this problem via endonasal approach, but as I said, I converted from endonasal to open, then I didn't return to endonasal, so now I feel most confident by open rhinoplasty approach. So I'm sorry.
So I think, yes, I think it's depend on the deformity. If it is severe, I think it's not easy to do the endonasal approach, right?
Yeah. Just generally, I think the mild deformity can be corrected much easier, either by endonasal or open. Yeah.
See, the other question. So, do you do primary septal rhinoplasty after trauma, or do you wait for some times, do close reduction, and do secondary septal rhinoplasty after several times?
It depends. But I usually don't do stage surgery. If the patient, so here's an important point. The nasal trauma is usually much more complicated than you think. So it's very important to have a thorough evaluation of the patient. So I think the CT is the most. You have to do CT scan in order to evaluate the degree, magnitude of injury. And you have to do a thorough endoscopic examination. Then if you convinced that if you are sure that there's no cartilage injury, no septal injury, if there's just bone injury, then we do just close reduction. But if there is any cartilaginous injury, if cartilaginous injury is suspected, I prefer to one stage correction of the bone and cartilage. I think it's just like a rhinoplasty. So I don't like the idea of staging.
Yeah.
Okay.
Okay.
Another question, Professor Jang. How do you prefer to fix the glued disc cartilage to the dorsum?
Oh, yeah. So I make a wide pocket, a skin soft tissue envelope, and then I insert it. It does not migrate. It stays there usually. And then I close the skin, and then I manually mold it, shape it. And then I place splint, external splint. Then it usually works very well. So I don't do any suture. I don't do something special. This just placement and massaging and manual molding after skin close, and then final shaping with external splint.
So the key is
I kept the splint about 6 or 7 days, and after remove the splint, I place taping about 7 or 10 more days.
So the key is the nasal spleen, external nasal spleen, maybe.
Oh, yeah.
Okay. So there is another. What is your comment on high incidence of resorption for diced cartilage as early as 1 year post-operative? Will the use of fibrin glue decrease the risk of resorption?
I don't think so. Recently, we surveyed, we did finish the study about 1 year follow-up. And this morning we submitted it to the facial plastic and aesthetic surgery medicine. So we measured using 3D scanner as a sophisticated technique. And then we realized that degree of absorption was not that great compared to even when you use Gore-Tex, there's some loss of height. When you use crushed cartilage, there's loss of height. But I think the diced cartilage with glued diced cartilage doesn't have that much resorption. The glue will resorb in early post-op. So the post-op 2 weeks result and 1 year result will be different. But that post-op 2 weeks result will reflect edema and glue. So about 1 month post-op, I think there will be no glue. So then about 1 month to 2 months, the result will be maintained at least in 1 year. Yeah, we may have resorption depending on how finely we chopped, diced the cartilage. I think that if we dice it too fine, I think
resorption a lot.
Yeah, there'll be increased risk of resorption. Yeah.
Okay, thank you. So another question. That's very interesting about the interposition batten graft. So if the caudal end is deviated to the right side, the interposition once on the dorsum side will be placed on the right side, and then the lower one on the left side.
Let me tell you.
Yep.
That's I always imagine the caudal septum, which has a little bit wider base and goes up narrower. Yeah, it's not exactly like Eiffel Tower, but it's similar. I want to have a structure which is really wide at the base, stable, and then goes up thinner. So in order to make that, I have 3 choices. I can use batten, and I can use cutting and suture only. I can use interposition batten. So it depends how it will be the final shape of the caudal septum. So I'm sorry, I cannot tell you the exact precise situation where you have to use this technique, but you have to imagine the desired caudal septal shape. Then you have some armamentarium in your hand. Then you can choose the techniques in order to make the caudal septum, which is straight in the middle, pressed in the middle, and little wide at the bottom, and the little narrow, thinner at the top. So that's what my concept.
Yeah. Okay, thank you. So there is also consideration about the external nasal valve, right? If you would like the middle crura to be wider. Is there any consideration of the external nasal valve?
Yeah, so by placement of this, you should not make the nostril narrow, but during my presentation, you probably see my cases that they usually has a bigger nostril and more symmetric nostril. It means that the caudal septum width itself does not impair affect that much on the external the external valve, nostril shape. But if we use very thick costal cartilage, it can be a problem. But if you are mindful at the end of the surgery, if you are mindful of the symmetry of the external nasal valve, And then you can adjust a little bit, and then usually not a big problem.
Okay, thank you.
So
Yep, Dean,
there is
any question?
there is a very interesting question to Professor Jang. Can you give tips on how to restart our rhinoplasty clinic in this time of pandemic?
A restart.
Yeah,
Okay.
restart after the pandemic.
Luckily, the Korean CDC did a nice job, and we didn't experience terrible outbreak. Yeah, we had our outbreak, but I think generally the infection is under control. I think it's collective effort of the government and hospital and private sectors and public sectors. So I think it's very difficult to tell the solution, because each nation has different situation. But here's what we do. When we do elective surgery, we do PCR virus testing a day before rhinoplasty nodule surgery. If they are positive, we don't do that. So we only do the patient who proved to be negative on virus testing just one day before the surgery. And we have very good contact tracing system throughout the whole nation. So whenever there is any new infection in a certain area, our hospital block and visit from the patient from that area. So all information is opened. So then that's why we can do practice in a safe manner. I don't know the situation in different countries, but when you see the patient in outpatient, you have to full protective equipment. And I myself use a mask, very good mask, and a facial shield and plastic shield. And I think the testing is very important, virus testing, and then also the system of contact tracing is very important. I think, but it cannot be done by any one single surgeon or one hospital. It should be a system, a collective effort by the government and Center for Disease Control.
Yes. Yeah. So I do agree with that. It depends on the policy of the hospital and the government itself. But as we know that this COVID flu, or we call the COVID-19, will always be with us in the future to come. So I think there will be a different way to protect ourselves using the PPE even in our clinic. Would you think so?
Yeah. I think so. Yeah.
Yes.
So do you do surgery using a PPA? I mean the level 2 or level 3?
No. Why? Because the elective surgery patient are already proved negative.
Okay.
Yeah. They can be in the stage of the latent infection, but they should have no symptom first. They should have no contact on the. They shouldn't have visit any place where the infection took place. So we have a thorough history, and we have virus testing. So during surgery, I do just as usual, but I use a better mask than before. We have
N95.
we have KF94 mask, which has almost a similar performance with N95.
Yeah, thank you, Professor Jang. I think it is a very interesting for us how to start the rhinoplasty clinic or the start for the ENT facioplasty after pandemic. So any other question from the participants?
Yes. This one, another one, Dean. Yeah. Do you feel any difficulty or different when you do rhinoplasty using all the hazmat pieces Google? Can you give us your tips on how to deal with using the N95 or N94 during the surgery, Professor Jang?
Yeah, as I said, during the surgery, I don't wear any face protection. I just wear the better functioning mask. But I got accustomed to the mask, so I don't feel dyspneic. Yeah, so yeah, surgery. I do surgery as usual. So yeah.
Okay. There is a question, Professor Jang.
Mhm.
What do you think of slicing the cartilage if you want to use a concave cartilage to overcome the curve? Do you use slicing cartilage compared to a walnut rasper instead of cutting?
I'm sorry, I got the you mean the sliced cartilage and
To
what?
overcome this, to overcome the curve in the concha cartilage, you use slicing.
Oh
The,
yeah. I dice it actually. I dice it, but I don't remove the perichondrium. I include the perichondrium very well. So the diced cartilage stick together. It's easy to control. So yeah, it can act as a lump. So the important thing is when you dice the ear cartilage, if you want to use it for camouflage augmentation, you better preserve the perichondrium around the dice cartilage. Then you can easily handle the diced ear cartilage. But if you want to it as diced cartilage, fascia wrapped diced cartilage or glued cartilage, you better remove the perichondrium.
So it
the
is
key.
one of the. Oh, okay, yeah, please.
So the key is the perichondrium. The perichondrium will attach the the diced cartilage. Yeah. Okay. So
Okay.
there is
another question.
Yeah, another question for the pre-operative. You mentioned that you do a testing a lot before 1 day before the surgery. Is a one-time PCR enough to exclude that the patient do not have COVID-19 before the surgery?
Yeah, I think that's important issue. There is no such a thing as 100%.
Yes,
but
because the PCR is about 70 to 80%, right?
Oh no, I think it's very sensitive. Yeah,
Okay.
I'm a kind of a virus specialist because I did a lot of virus study. I think I don't. I think it's very sensitive. So as I said, not only the virus testing, we do thorough history taking, where they visit before the surgery, where they meet. So if there is any suspicion, we neglect the surgery. And sometimes the problem is, I did the surgery on the day 2, and the patient developed fever. Yeah, it makes me very nervous. Then we do virus testing again. So I have number of patients who develop fever after the surgery. No patient who tested negative have tested positive after the second testing. So I think PCR virus testing is very reliable.
Okay. If you, this is another question. When we're doing the rhinoplasty for managing this problem, especially for the dorsal graft technique, sometimes it's difficult to make a nasal frontal angle naturally, naturally. Is there any trick from you, Professor?
Yeah, so especially when the patient has very acute nasolabial and nasal frontal angle, it's very difficult. So I think if we just think about the nasal frontal angle, I think the best way is the prefabricated silicone. Yeah, but I personally don't like I don't use the silicone, so I try to soften the angle by putting a cartilage graft. It can be crushed cartilage or diced cartilage with or without fascia. But the shape is not that satisfactory. So I think that's the difficult part of the rhinoplasty. But fortunately, not that many patients has that acute nasal front angle. Usually, if we do decent job in augmenting the nasal dojum, they usually have nice looking dojum. So majority of patients, you can have a very nice result. Not considering this nasal frontal angle that much.
Mm.
So
This is
a question, another question.
Mm-hmm.
Do you have any consideration for teenagers or pediatric patient?
Surgery on the pediatric patients?
Yes.
yeah, rhinoplasty.
Oh yeah. So if I have a patient who is about 16, 15, who visited with deviated nose and some severe functional impairment, I interviewed them. I catch the level of frustration in terms of the shape and function. If they are in too much frustration, then I go on. So my youngest patient who underwent extracorporeal septoplasty is about 6 or 7. Poor boy, totally blocked the nose, couldn't breathe through his nose at all. So I did extracorporeal septoplasty for the poor boy, and I found that the surgery didn't affect normal nasal growth. So yeah, I'm a little bit careful in selecting the pediatric population, but if the patients are in a real trouble, if they cannot breathe, they have real psychological issue related to the nasal shape. As a doctor caring for the whole patient, I think there's no reason for us not to do the rhinoplasty.
Okay,
Yeah.
but that means that there is a certain part that from the nose that we should avoid, the area that the point of growth in pediatric nose. In which part? Yeah. In which part?
I think it's well published in the literature, but when I do pediatric septorhinoplasty, I minimize the removal of the quadrangular cartilage. I minimize removal. I just remove just mid part, inferior mid, small part of the cartilage if I need to do that. But instead, I rely more heavily on the grafting using bone or not that big one, additional cartilage from ear or costal cartilage, but in most cases, I think yeah, it's really more difficult because it's small nose, but in most cases, if you have a good concept of the structural grafting and usually the bad sequelae can be avoided. Yeah.
So it's more a conservative rhinoplasty, maybe a Prof.
Yeah, minimize the resection, removal of the quadrangular cartilage. Yeah.
Quadrangular cartilage. So another question, Prof. Dr. Beatrix. Thank you for your presentation, Professor. I would like to ask, in your experience, what do you do to prevent recurrent post-septal rhinoplasty? Is there any education for the patient to reduce recurrence?
Recurrence?
Yeah.
I think the most of the recurrence is related with the strength of the cartilage. And so I think it's mostly a surgeon's factor or technical factor. But one thing the patient have to be careful is having try not to have trauma on the nose. I think that is the only thing the patient can do. They should not involved in the physical activity which is prone to incur the injury in the nose. So that's, I think that's only part for example, if the girls the patient like soccer or football or basketball or things like that, boxing should be avoided absolutely. So those kind of thing, except those kind of thing, I think what we have to do is that before surgery, you have to inform the patient that it may look straight in 6 months, in 1 year, but it may look deviated again 2 years or 3 years. I think warning before the surgery is very important. Then they can understand. When the problem happens, they become less upset. If they are not informed about it, they usually blame the surgeon, and so they got upset. So
so
it's
the
very important to have a good conversation with the patient, especially the deviated nose. So I always tell the patient before the surgery, I will do my best, but the correction may be about 60 to 70% of what you expect to have.
Yeah. Okay. So a good communication and informed consent may be appropriate. Another
question from Renato Pascual.
Yep.
A question. So can we use the temporal fascia in disc cartilage in your mold? And
sure.
should it be just on the dorsal side, like on the video, or it be wrap the whole cartilage?
Let me tell you, the reason why I devised this, use this technique is in Asian rhinoplasty, I think in order to make a very big fascia wrapped disc cartilage, you have to harvest a very big temporal fascia. So I think it's impractical. So I don't want to make another mobility right here. So by placing the fascia on one side of the glued disc cartilage, you can minimize the amount of the fascia harvest. Then you can reduce the mobility. So I always place the fascia just beneath the skin. It's convex aspect of the implant. I don't place the fascia at the concave side. I mean where the implant is in touch with the major dorsum. I don't place a fascia. I just place fascia just under the skin, to prevent any probability of the irregularity or pebbling caused by the disc cartilage. In a thick-skinned patient, you don't need to place the fascia in between, but in patient with very thin skin, I think this can minimize the risk.
Yeah, thank you. Any other question, Dr. Riyad?
Yeah, I have a question for you, Professor Jang. So you mentioned that to correct a deviated nose, the main issue is to correct the septum, right? Then after that, the external part, and then still you often have to use a final refinement.
Oh yeah.
How often do you use this final refinement, or is it mandatory in every deviated nose that you use a final refinement such as augmentation or camouflage?
Yeah, I think it depends on the native shape of the nose. But and also it depends on the thickness of the skin. If the skin's thickness is, if the patient has not that thin skin, and at the end of the surgery you have satisfied the dorsal line, you don't need to put the camouflage or augmentation. But the thing is, most of the patients who are seeking rhinoplasty deviated correction, they also hoping to have nose which looks bigger, more defined, more augmented in this part of the world. So I think I do about 80 to 90% of the patient. I do augment the dorsum. I do some camouflage. But I do sometimes I do the nose for the Middle Eastern patient, and I don't augment the dosage. If I need, I just do a little bit of camouflage.
Okay. A question from Dr. Rano, I think. This is how to overcome a drooping nose post hypophysis neurosurgery. The nasal mucosa often have synechia, and sometimes the cartilage is scarred already.
You mean the hypophysiectomy?
Yep.
Yes.
After.
True. Septal. True septal.
I think the it's important to preserve the integrity of the septal cartilage is very important. But during procedure, we sometimes focus on the area of interest, then we neglect the dislocation of the caudal septum from the anterior spine. Then you may end up with saddle or deviation. So when you close the hypophysiectomy, check the position of the caudal septum and integrity of the caudal septum. If there's something wrong, I think you have to explore the caudal septum and you have to reconstruct the caudal septum. I think if you didn't remove the cartilaginous septum that much, you don't need to worry about the tip drooping or saddling. It's usually because of the unrecognized injury on the septal cartilage. Or dislocation.
So maybe when you do a transnasal hypophysiectomy, we just like a swinging door from the cartilage without resection. Is it possible, Prof?
Personally, Prof, I don't like swinging door technique. I hate it.
So why? Why?
Yeah, it disarticulates the caudal septum from the.
Okay.
I think it has very high risk of decreasing the caudal septal height. After you try to re-stabilize the caudal septum with the nasal spine, but in many cases, the caudal septal height is already decreased. So I have many patients who develop a saddle. In my hospital, I had one senior surgeon who do septum exclusively using that technique. I have many saddle patients who developed saddle by his surgery. So I don't want to blame the swing door technique, but you have to understand that the caudal septal height and caudal septal stability is number one important factor for preserving the nasal shape. If there's any dislocation, unrecognized, a shortening, there's tip drooping, deviation, saddle, so everything can happen. So I respect this caudal septum alignment where the caudal septum and nasal spine, I keep it very sacred. I think that it's sacred area you have to respect.
So we have to reconstruct or reposition it to the normal side of the nasal spine and the caudal septum, right, Professor?
Oh, yeah.
Yeah. Okay.
But
So
without the swinging.
Swinging.
At
least you have to replace it. You have to replace it to the normal place.
Yeah, that's why. Because I don't like swinging door technique. That's why I use so many maneuvers to correct the caudal septum, baton, bony baton, those things. Those things I try not to dislocate intentionally the caudal septum, the junction between caudal septum and nasal spine. Sometimes there's a dislocation, unexpected dislocation, then I try to reconstruct it very firmly.
Another question, Prof, from Dr. Mirta. Do you think using columella strut sometimes could make tip rotation? Can you give any tips to using columella strut without making the tip rotation according to the length of the columella strut?
Oh yeah. Usually the columella strut can result in tip rotation. Unfortunately, these days I rarely do columnar strut for during rhinoplasty. The only occasion I place columnar strut is correcting the shape of the column. Let's say if it is too narrow, I place columnar strut to make medial crus a little more wider. But instead of the columnar strut, I mostly use septal extension graft. Then we can easily control the angle. We can derotate, we can rotate, and we can have much more formal and stronger caudal septum. The only problem we have is that stiffness of the nose and tip. But if the patient can overcome that problem, I think I personally I don't use columnar strut these days. I rely more on septal extension graft.
Okay. So your preference is more to use septal extension graft beside towards the columnar strut, Professor.
Yeah, that's correct. Yeah.
Another thing is important. You mentioned about the facial asymmetry. Yeah, in cleft lip nose, Professor Jang.
Cleft lip nose, yeah.
Yeah, we often have this intrinsic factor that causes not only the facial asymmetry but also the nasal asymmetry. Yeah, because of the intrinsic factor. So, which part do you first reconstruct, the foundation of the nose, or you can go directly for a reconstruction of the deviated nose?
The thing is, unlike your practice, I know that you do a lot of cleft lip yourself, but in my hospital, we have excellent plastic surgeon who does all the cleft lip work. So the cleft lip nose I experience is usually secondary cleft lip patient who search it by themselves and just find me as their surgeon. And so I only have secondary cleft lip nose patient who already undergone lip work and some of the skeletal work. So if they don't have that severe facial skeletal abnormality that have to deal to it before the surgery, I do the rhinoplasty. So, but I think it's better to correct the other issues first. Yeah, then the definitive rhinoplasty can be done as a final step. That's my opinion.
Yeah. Thank you, Professor. Another question from Satria. When we're doing the rhinoplasty in elderly patient, with deviated nose, sometimes the result of the nose is shown more tight than the other parts of the face. So it's reduced the level of patient satisfaction. Is there any tips from your experience doing rhinoplasty in education?
I'm sorry, I couldn't get it quite right. I mean, in the senior patient.
Yes, when you do a rhinoplasty, post-operatively, you will see the nose is more looking younger than the other parts of the face. So how to reduce this level of patient satisfactory? Is there any tips of your experience? So the nose fits well in the age of the patient.
Okay. I think it's not a problem I had to thought about before, but yeah, I have a number of patients who is their 70s, 60s. Yeah, I think the 60s is not old. Yeah, 70s, but usually they are happy with the new nose. But I don't have any complaint that there is no balance between the wrinkled face and the nose.
So the young nose, the facelift, I think.
They prefer young nose. Yeah, the thing is, we don't have a wrinkle in the nose. So,
yeah.
So,
young nose and then continue with the facelift. You agree?
Yeah, but I don't do facelift by myself. So I can tell you that the senior people who are interested in the aesthetics of the nose, they already seek the skin treatment and facelift elsewhere.
Yeah.
Yeah.
So I think that finishes for the questions side from the audience or the participants. So we have nearly already 2 hours, going to be 2 hours. So we would like to, on behalf of the Collegium, College of Otorhinolaryngology Head and Neck Society, would like to express our appreciation to Professor Jang. A pleasure for us having you here in our session. And then I think all the participants have benefit from our lectures, our meeting. And thank you again, Professor Jang. I will send back to Dr. Lina as the host. Dr.
Thank
Lina.
you, Professor Jang. Thank you very much.
Thank you, Dr. Ria and Dr. Dini, our gorgeous moderators. And thank you, Prof. Jang, for your excellent presentation. We appreciate it all. And then thank you for all participants. And don't forget to fill the feedback form as it written in the chat room. And I think I have to end this session. Maybe. Thank you all and good day for all. See you in next program. Thank you.
Thank you, Professor Jang. Thank you.
Prof. Jang.